Hello everyone and welcome to our second primetime debate dedicated to how to repair soft tissue defects and how to manage when things go wrong. Let me introduce you to the chair of this primetime debate, an implant dental surgeon and specialist in periodontics, Isabella Rocchietta.
Hello, Gerhard. Good evening, Gerhard, and good evening to all of you who are listening to us tonight.
Yes. Now, before we get started, let me remind you one more time that we are live and it's important that you participate in this debate. So at any time, if you have a question, a comment, or anything that you would like to add to the debate, make sure you use the options to be interactive. Use the chat or the questions below and submit it straight away.
Well, Gerhard, I am very, very pleased. You know why? Because we are here today to discuss something that is rarely discussed around meetings, which is failures. Normally, we all are very proud of our work and we like to show off, let's be honest.
It's been said on the congresses, everybody shows the perfect cases.
Everybody shows the perfect cases, but you know what? If you're a clinician and you work every day, you get once in a while some complications, and it's from those that you learn.
Exactly.
So I'm extremely happy to be able to share amongst 4 experts something that is extremely on an everyday basis that happens, which is the soft tissue complications. Now, we will divide tonight into 2 macro topics.
Okay.
And we will discuss about the immediate soft tissue complications, which happen right after surgery within the 14, 21 days, which honestly is a little bit of a disaster, and we'll go into it.
Yeah.
And then we will discuss about soft tissue impairment, so something that happens on the long term.
Right.
So things may look beautiful after a few months or maybe even years, but what happens down the run? So yeah. I would like to first of all introduce our 2 debaters.
Yeah, we have a few rounds of debate ahead of us before we go into a broader discussion, so please invite them.
So, let me first introduce to you Dr. Gerhard Iglhaut from the University of Freiburg and Andy Temmerman from the University of Leuven in Belgium.
Wow! What an entrance! Welcome, gentlemen. Looking stunning. Ready for the debate?
Well, you know, I want to share with you, gentlemen, something that occurred to me many years ago now. And we all know, as we said, that if we do extensive hard tissue reconstruction, we may end up, if the soft tissue management is not perfect, we may end up with some sort of soft tissue dehiscence. And I would like to share with you something that happened to me during my number 4 surgery of my life. So many years ago, I have to say, Gerhard.
It's only very recent, I would suspect.
No,
exactly.
But many years ago.
Your 4th ever surgery, and you still remember it.
Yes, I do, because as we know, we learn from our mistakes. And the 4th surgery was a vertical augmentation in the posterior maxilla, and funnily enough, it was a friend, the boyfriend of a friend, who then, well, she dumped him, so I didn't have to see him again, so that was fantastic. But anyway.
Great background story when we look at the pictures.
But let's look at the pictures. And when I obviously was ready to remove the sutures, you may notice the pictures are lousy. It was many, many, many years ago, the old generation titanium reinforced PTFE membranes. But look what happened 14 days later. I call it the monster of Loch Ness, because the green pus was pouring. So now, jokes aside, this is an unfortunate event, and our duty is to prevent this, and our duty is to avoid this. And now we have the tools, the knowledge, the science, but here we are. Now, I am asking you guys, what is your opinion and how to deal with soft tissue dehiscences right after augmentative surgery?
Exactly. So to kick off the debate, we have asked all of our experts to prepare a little 3-minute pitch, and we'll keep them to the time to explain why their proposed solution is the best one to deal with a soft tissue issue. So, Gerhard Iglhaut, you are the first to take the floor. You have 3 minutes to convince our audience and our colleagues here in the studio. Are you ready?
I'm ready.
Gerhard, yes. Take it away.
Yes. If you perform oral surgery, you often face less or more problems you can see on the screen, and how to deal and overcome with it. I want to show you now in a case following. Please, the next slide. Here you see this patient 11 years ago, where his desire was to get fixed restorations on the upper. So we performed implant surgery. First of all, I show you on the next slide the X-ray, where we see we do horizontal and vertical bone augmentation with sinus elevation. Next slide. And then we use this technique now, this 12U, which is a special technique we call shell technique with polylactide membranes, which can be formed in a water bath and fixed by melting and pins on the bone. And the box is then filled with bone material, which is a mixture of autogenous bone and xenogen material. We cover it with collagen membrane and close it. Then you can see on the next slide what comes up when we already had removed the sutures. This is about 4 weeks later. This was pressure of the removable, and so the patient didn't take care of it. So what to do now? We want to see now on the next slide. We remove these plates and then clean up this wound by rinsing with Chlorhex solution and use here ozone gas. And then we clean up more with a special paste and avoid infection and control infection, which is topical antibiotics, which is a gluing paste, which fixes to the tissue, and we cover it. So we tell the patient, do this 3 times a day and come back every 3-4 days. And you see on the next slide what comes up. This was only 2 weeks later. We have a nice secondary wound healing. And if we see 6 months later, the next slide, we can now augment, can now insert the implants, re-augment a little bit and close it again, and then come back in the next slide 3 months later, open it up, abutment connection. On the left side, you see the final restoration, fixed bridge. And on the right side, you see this is about 11 years later, perfect healing and fixed tissue, and you see the same on the X-ray. Thank you.
Thank you. Well in time. We hear the countdown going. And well, congratulations, Gerhard. A very clear explanation of a case that went wrong and how you solved it. Let's go straight into our next debater, Andy Temmerman. Also, you have 3 minutes to convince our audience and explain to our audience what your proposed solution would be when you have a soft tissue complication. Are you ready, Andy?
Yes, I was born ready.
Take it away.
So healing problems and post-operative complications, all clinicians will have to deal with them. And those who say that they don't have any of those, they probably should do more surgeries, because they will come, I can promise you. Now, wouldn't it be nice to have something at our surgical table that really enhances the soft tissue healing, is available in large quantities without you having to go to a second surgical site, release of growth factors, and is also very easy to handle from a surgical point of view? Now, as you can see, a platelet-rich fibrin product is, per definition, a touchable biomaterial. Therefore, it's shape-cuttable, it's suturable, it's 100% autogenous, of course, and it has a fairly easy preparation protocol, releasing growth factors for up to 7 days. Now, as we know from studies, an interpositional layer may absorb the tensile forces and also the transmission of those forces to the underlying delicate fibrin clot, thereby enhancing the concept of wound stabilization. Now, as you can see, indeed, in these kind of procedures, LPRF is placed below the mucogingival, the mucoperiosteal flaps in direct contact with the gingival connective tissue. And this means that this way of action actually is threefold. Now, firstly, LPRF is placed in direct contact with the gingival connective tissue, and therefore this connective tissue is also rich in fibroblasts. Now, recently it has been shown that PRF is able to grab those fibroblasts in order to make them more responsive and active to close a wound by specific up and down regulation of genes for which I am too stupid to understand.
But
then
it works.
Secondly, LPRF is in direct contact with a membrane during GBR procedures. And recently it also has been shown that PRF is able to activate an avascular collagen membrane in order to enhance its vascularization and also angiogenesis. And thirdly, it has also been shown by our department in Leuven that LPRF has also some antimicrobial capacities against periodontal pathogens, which are, of course, present in the mouth of our patients. Now, of course, I think our correct surgical techniques, soft tissue management, the knowledge of the anatomy, and so on, are the cornerstone of our treatments, and probably LPRF will never change this. Nevertheless, when you have suboptimal surgeries, like, for example, this one, where we can discuss on flap design, etc., PRF might just be strong enough to overcome a soft tissue dehiscence, closing up the gap, activating the fibroblasts in order to close the wound in up to 4 weeks, as you will see in this series of slides. And that is also the reason why PRF has been a part of our protocol in Leuven for already 6 to 7 years.
He managed it.
Wow, he did well, eh? Yeah, he was waiting for his last slide, but there was the gong. Congratulations, Andy. Congratulations and thank you to you both. Obviously, we are aware that this is pretty tough to do your entire story and pitch in 3 minutes under time pressure in the lights and cameras with all of you watching. So thank you for that. Now, Isabella, we heard the first two potential solutions to how to manage when things go wrong. Can you briefly reflect on the differences or similarities?
Of course, Gerhard. I'm looking forward to the debate, because tonight is a debate. That's why we only gave you 3 minutes, because the core will be afterwards. So we will get into the details. It's quite evident, however, that the two approaches are honestly very different, because we have a more traditional approach where you acknowledge the soft tissue dehiscence and you clean out what has been exposed, and then you have your protocol to decontaminate and to avoid further loss, and we will talk about this. So allowing for secondary intention, so in a way allowing Mother Nature to go for it. And of course then we have something that is completely different, so aiding and in fact possibly even preventing the soft tissue dehiscence. That's the aim. And I'm looking forward to get into this, because of course there are 1,000 of things in my head that are running up to now.
Exactly, but this table is not fully filled yet. So let's do round 2 first.
Okay, so round 2, which I love this name for, is still a soft tissue complication, but this time a soft tissue complication that may occur at a later stage. Let's, for example, think of those beautiful, magnificent implant cases, like an immediate implant restoration in the anterior. Beautiful for 1 year, beautiful for 2, but what happens down the line? And suddenly we have cases with recessions around implants, and this is a soft tissue impairment. This is a severe soft tissue impairment, especially for people who have obviously a high smile line who show. Now,
so let's bring out the debaters to talk on that.
Yes, absolutely. So I would like to introduce our brave debaters for the second round. So we have Arthur Noaves Jr. from the University of Sao Paulo, Brazil, which I'm thrilled that he's connecting via Zoom. Hello, Arthur. Lovely to see you. And of course, Ignacio Sanz Martin from Lausanne in Switzerland, who's here live in Paris with us.
There he goes. What an entry. Thank you. Welcome, Ignacio. Welcome, Arthur. Glad you're joining us.
So before we actually give the podium, the 3-minute pitch, which is a challenge to these gentlemen, I would like to show you simply an image of cases that may enter our door on the Monday morning. We want to be very clinical today, so I want to share with you cases that require treatment, and I will then obviously get into you specifically and ask you why and how. These are my main questions. So, shall we start?
Yeah, do you want to say anything about the case that we say now?
The cases for every implant surgeon, these constitute the nightmare. So there's very little to say other than these are soft tissue impairments, recessions around implants, and we have to understand A, the cause, and B, how to prevent, of course, but if this happens, because it may happen to us, I never want to say it happens to the others, because this is absolutely...
This isn't your 5th case?
No, this is not my 5th case. No, thankfully, no. The learning curve goes up, usually.
Exactly.
And, but certainly, these are cases that we have the duty and to treat for our patients, and we have the experts here with us.
Well, let's find out what we can do. Arthur, we would like to start with you. We would like to also give you 3 minutes to convince our audience why you have a solution for and a treatment plan to how to deal with these type of soft tissue defects. Arthur, are you ready?
Yes.
All right, then the time starts at your first words.
Okay, thank you. In reality, I would like to avoid such problems. No? I don't know if these were immediate implants or not, but you have to, when you're planning the case, I think the mistake goes back to the treatment planning. And to begin the treatment planning, you have to define what gingival phenotype you have. So if you have a thin or medium gingival phenotype, you know that you're going to have to use some kind of soft tissue graft with your surgery. Second, you need a tomogram to define the bone phenotype. And if it's usually around 1 millimeter, the buccal bone plate, that's one information. And then you also measure the buccal palatal dimension. So you have to know that if you place an implant, 3.5 millimeter in the anterior area, for example, a little more palatally, and have a gap of 2 millimeters between the implant and the bone graft, and then you have a 1 millimeter buccal bone plate. When you add 2 millimeters of the grafting material to the gap, you have a buccal bone plate about 3 millimeters. And if you had a gingival phenotype, you would also have the correct type of gingival tissue covering. So I think these cases are more easily to prevent than to treat. You have a surface that is already contaminated. The implant, obviously, the treatment planning that I described was not followed. So the implant is probably in the wrong position. You probably have a thin buccal plate, and you're going to have to try to reopen that and regraft and use guided bone regeneration. But you have to remember that that surface is contaminated, which is a very difficult situation. So in some cases, you have to remember, if it's not your patient, once you accept that patient, you treat it or you touch it, you own it. So you have to solve it all the way, which is a problem. So in many cases, you might have to remove the implant and start from the beginning. So that would be my concern when I see all these cases, and we see it all the time. It starts with the treatment planning, the wrong planning. And that's what I think I can contribute.
Perfect, Arthur. You have 10 seconds left, so that is wonderfully on time. Thank you for that first elaboration on how you would deal with soft tissue defects, basically saying, well, you should prevent it. And if not, you have to perhaps take it out. And a very important remark about owning the patient if you touch it. All right, we go to our fourth and final debater to give you time for your 3-minute pitch. He's already smiling from ear to ear. Are you ready, Ignacio?
I am ready.
Yeah, you have 3 minutes to convince us why your treatment plan would be the best option to deal with these kind of defects. Okay. Take it away.
So soft tissue dehiscence or recessions around implants are conditions, as you've seen, where the prosthetic component or the tooth is longer and creates an aesthetic problem for the patient. So my task today is to advocate for autogenous connective tissue grafting around implants. But before I get into that, I'd like to briefly touch on the etiology of this condition. And we've performed research to try to better understand why these dehiscence occur and try to better understand the factors that are associated with the presence of this dehiscence. We've looked at over 100 patients, 52 with dehiscence, 52 without dehiscence. And the bottom line of this study is that the root of the problem is the position of the implant. It is the position of the implant that's going to shift the bone apically on the buccal. It is the position of the implant that's going to make the soft tissues thinner, and they're eventually going to have migrate apically because of the pressure of the prosthetic reconstruction. So first thing that we need to try to understand is, as Professor Novai said, are we going to treat these cases? We have cases where perhaps we need to perform an explantation. You see a picture on the screen of an implant that was positioned far way out of the buccal bone. And in this case, unfortunately, we had to perform an explantation. Every time we perform an explantation, we're going to have to perform extensive bone augmentation to reconstruct the bone and be able to place these implants again and perform a reconstruction for the patient, a fixed reconstruction for the patients. So when we decide to treat these patients and when we decide to go for coverage of these recessions, first thing that we need to try to do is compensate for the buccal position of these implants. And a lot of times we're just going to try to focus on leaving enough soft tissue or making enough soft tissue for the patient. You have here a case where you see an implant with a dehiscence on number 12. You see the position of the implant is very much angulated towards the buccal. And here what we're going to do is a combined surgical and prosthetic approach. We cannot fix these cases just with surgery. So you can see on the next slide that actually what we did is a thin, narrow abutment. This has no margin, and the objective here is try to leave enough space for the soft tissue. And what you can see is just by changing the provisional, by putting another abutment 1 week after, you see a coronal migration of the soft tissue. And it is then, after we change the abutment, that we can then perform the augmentation procedures. When we perform the augmentation procedures, next slide please, we've actually performed research that tells us that it's not the location where you harvest the graft, but rather the quality of the graft. That is, we need to be harvesting grafts that have a high content of lamina propria. The lamina propria is the tissue that is right beneath the epithelium. It's not so important whether you do it from the tuberosity or whether you do a free graft that is de-epithelialized. What is important, it has a big content of lamina propria. Also, we need to understand the location of the implant. Whether you do a coronally advanced flap or a tunneling procedure, the location of the graft in the transmucosal region is of paramount importance to treat these recessions.
Wow,
Whoa,
beautiful. You made
impressive.
use of your time. It was impressive. And again, let me express, Arthur, also to you, we are aware this is rough, but that's also why we like to do it. Put some heat in the debate.
Of course.
And to make sure that in this first 15 minutes we've kicked off the topic, we've explored the topic. If you reflect to these last two debaters, what do you hear in terms of differences or similarities?
Well, Gerrit, now the actual heart and the core of the debate comes into action. And by the way, we are fresh with the presidential debate, so guys, please do not...
We have a mute button.
we have the mute button, so please do not copy our American leaders, please. So I would like to pick up something straight away. So we are, I think, all very much aware that the malpositioning of the implant is possibly, can we say, the cause, number one, of a future then risk, at least, of soft tissue recession. So what do we do? I mean, for the people who are looking and watching us, what do we give them as an indication? Of course, everything comes down, as Arthur was mentioning, about the planning. This is something that I want to reiterate because it's extremely important. But I also want to cite a paper that was published by the Zurich group, where if we want to achieve an excellent result from a functional and an aesthetic point of view, they have noticed that in reality, 50% of the result is thanks to the hard tissue, but 50% to the soft tissue. So my question is, we do need that connective tissue at the time of implant placement. Do we? Yes, no, maybe, and if yes, can we replace this? Because we have other alternatives. So can we please a little bit brainstorm on this topic? I would start with the last debater. So what do you think nowadays, knowing that you get into a potential risk? What do? Do you add, irrespective of implant placement timing? So I'm not asking whether you're going to do it on an immediate implant or an early implant placement. If you do both, when and how do you put that connective tissue? Do you put it, or do you just wait and pray that nothing will happen?
So for me, first of all, I would try to understand what are the patient expectations. Is it a patient, are we treating an aesthetic zone? And for sure, if that is the case, then I'm going to be more likely to perhaps have to enhance the soft tissue with a graft. But if you allow me just to briefly touch on the timing, I think that's critical, because what we know is that when we extract the tooth, if we do nothing, just by extracting the tooth, the tissue is going to just take the space that the bone leaves from the resorptive process, and those are the studies from the Bern group, from Vivian Chapuis. And what she says is, you take the tooth out, you extract, and the tissue just becomes thicker. So if you go for a delayed approach, we see amazing results without connective tissue. If you try to implement immediacy, then obviously you are not going to be able to do that, and you need to count much more on connective tissue grafting, especially if you're doing it in the anterior zone. If you do it in premolars areas, not so much. If you do it in molars, not so much. So that would be my take on it.
Would you, gentlemen, would you agree on this on this statement? That when you perform an immediate implant, I don't want to deviate and speak about immediate or early implant placement, but would it be a message that the soft tissue constitutes a very important role at the very beginning of the pathway?
Yeah, I'm quite sure, because at our department we are very much keen of delayed implant placement, not so much immediate, and we do always the same protocol. And then, like Ignacio says, we don't often see the need of an augmentation because of what he said during what the studies from the burn group are very, very evident in that case. When you go for immediacy, that's what we do now. We try to augment, yeah, as much as possible. But this is, I think this is aesthetical zones. I think what is very, very interesting is the functional zones. Posterior mandible, for example, is totally different when it comes to augmenting the soft tissues and so on.
Can we extrapolate on that? Why do you say it's completely different? I fully agree. And let's speak about the famous attached gingival keratinized tissue around our restorations. We know it aids the patient when it comes to cleaning and hence maintaining on the long term. And last night, during the primetime debate, we heard Mario Rocchietta, for example, mentioning that he would increase the keratinized tissue with a free gingival graft prior to his augmentation surgeries. I personally have my opinion on this, but this is not about opinions, it's about science. So where do you stand? What do you do? Have you ever augmented prior to, just in case? And I'm specifying, and I'm only speaking about the non-aesthetic cases.
Yeah, I think we tried now to augment during the healing phase of an augmentation procedure, because sometimes you need to wait for 6 to 8 months. Then you have the time to go over the soft tissues. But what I find very interesting, because of the amount of keratinized tissue, is something that in literature always comes to our minds, but we never talk about the attachments. And why do we not talk about the attachment? That's because there are no studies. We cannot measure the attachment, but I think that's much more important than the amount of keratinized tissues that we have. And are we going to have a solution for that in the near future? I don't think so, because we will not have the papers to support that. But this is what you see in patients when you retract the cheek of your patients in the posterior mandible. Even when there is keratinized, you see it moving up and down. I don't think that is the ideal starting situation for our patients. So think about the attachment is something that I would do.
And how would you improve that? It's a touch.
There has to be enough keratinized tissue that is also attached. So that means that the connecting fibers need to touch the periosteum of the surrounding bone. And this is a very surgical thing, but to do in 2 to 3 minutes is a little bit difficult.
Because nowadays, the protocol after, for example, severe vertical augmentations in the posterior mandible, we perfectly know that, for example, if we use the technique of GBR with titanium reinforced membranes, I now get into my
previous debates,
slightly biased area. We perfectly know that the keratinized tissue, by the time we end up, because of the release of the periosteum, we eat away, if I may use very simple terminology, the very thin keratinized tissue that we have. And this is the reason why I would say 99.9% of the cases, upon second stage surgery, we have to augment the famous keratinized tissue with simple free gingival grafts. These are techniques that were described many, many, many years ago. But I was intrigued yesterday when they were saying, let's prevent the soft tissue dehiscence, like Mario was mentioning with the titanium meshes, by doing a free gingival graft beforehand. But what about if we had other tissues other than autogenous? And here now I want to open it up. And Arthur, please join in. We see you very clearly, so you're sitting amongst us as well. And what about other biomaterials? What are we're in 2020, guys. Is it possible that we still need to harvest big steaks from our patients? Can I use this terminology? It's evening. I think it's very clear. It's dinner time. It's very clear.
Very visual.
we have listened to your presentation showing alternatives that may or may not be the way forwards. What do you think? Do you think there are alternatives to soft tissue grafting instead of using the connective tissue? What are we going to do to these patients, guys? We really need to find something, and I want to give take-home messages because we are here to do so.
Absolutely, we have new techniques, we have new materials, and which shows absolutely nice outcomes in the last 5 years. We have no studies yet on this, but I'm convinced that we should avoid this morbidity for the patient. They hate that we harvest from the palate. And we need a lot of volume often, so we are limited in the availability, so we need other products, biomaterials, and I think what is the next step is material which we call cellular dermal matrices, which are from xenogen origin, porcine origin. So these materials, from my opinion, yeah, they could be the solution in future. We will see in studies.
Do you think in the future we will then stop doing the autogenous graft altogether?
At the moment, there are some situations I cannot avoid it. But I can avoid to harvest, let's say, a free gingival graft and a connective tissue graft. But what I'm using often to closure in the aesthetic zone, immediate implants, I use combinated grafts to have a wound closure without any surface incisions, because I don't want to destroy the architecture. So with this, I can thicken my tissue and then can do, in my abutment connection, a roll flap. And always, for me, it's volume, volume. I want to have as much as I can, but the problem actually is to use these materials to have it in an open healing, so how to avoid infection. This is the problem, from my opinion, because now we have to cover it.
Of course, of course.
This is the problem, actually.
Of course.
We have to overcome this.
Yeah, but still, I still believe the autogenous tissue, if I look at your papers and what you have brought us, first of all, let's remind ourselves that we cannot have our own personal opinions. I understand this is very new, but we have to have some evidence behind our backs. So we can say that the autogenous tissue at the moment, it's still the gold standard. Can we say this?
Mm-hmm. Yeah, Arthur, come in.
Yes. Actually, I think that the connective tissue harvesting from the palate is kind of medieval. Eventually, it will not happen. And but still, there is use for it. And that the situation you were just discussing is one of those situations, because in the posterior, where there's no aesthetics, we have to remember that the basic differences between connective tissue graft and an allograft, for example, is that the connective tissue has the genetic information to be placed over mucosa and form keratinized epithelium. The allografts, xenografts, they're just 3D collagen matrices. So they don't have that genetic information. So they're not able to change the phenotype of the region.
Correct.
If you don't have the keratinized tissue, or just very little, or just mucosa, the allograft would not be indicated. If you want to increase the area of keratinized tissue and maybe the thickness, this is one of the places where the autogenous graft will still be, is still indicated, in my opinion.
This, I think, is a very important point.
I cannot agree to this.
You don't?
No.
You disagree?
Tell us why. Here comes the debate.
Because we don't need keratinized tissue, for my opinion. What we need is volume of soft tissue and fixed mucosa.
Yeah, it depends on the indication, though.
Yeah, but do we need keratinized tissue? We need fixed tissue. We need, let's say, 4 to 5 millimeters of fixed tissue. This is important.
4 to 5, that's intense.
Yeah.
That's a lot.
Why?
We were always speaking about the 2 to 3. Okay, no, but I like it. Carry on, carry on.
Yeah, and this is for me the topic. We often discuss about this because we're using such materials, you know, from Pat Allen in 2001, allergen materials in recession treatment. And you see how much fixed mucosa you can gain and how you can avoid let's say, all the muscles to work on it. So this is a very important prospect what we should always think about. It's volume and fixed mucosa. We don't need...
Arthur from Brazil is shaking in his chair.
I see Ignacio also pulling up his lips. Yeah?
I could not disagree more.
Okay,
but
here we are.
Help our viewers understand why, because this is interesting. This is what the primetime debate is all about. What makes you say that you so disagree?
First, that I work with the alloderms just as long as Dr. Allen, and for root coverage over the tooth, it's completely different, right? We have techniques to be used. You cannot use the same technique for autogenous graft and for the allograft or xenograft. We have designed through the years the ideal technique to be used with the allografts or xenografts. So if you use these techniques, you get as much as root coverage as you can and also some kind of attachment, right? Now, you do not form keratinized tissue. If you have some keratinized tissue, and you use an allograft, then you'll be able to form also some keratinized tissue. I like keratinized tissue, especially around the implants. And 2 millimeters, as we said, that's what you need to maintain the implant healthy. More is better, but it's a completely different situation.
No, Arthur, I absolutely agree that let's not mix the two fully different indications. One is the root coverage and one is what we are actually talking about, which is the peri-implant soft tissues. Ignacio, do you want to...
He started it.
I know. Okay.
Started it.
You're right. Okay, I'll whip him here live from Paris. Ignacio, do you want to defend your thesis about the connective to the autogenous tissue? Because he said it's medieval. I mean, it's a big statement.
I think, you know, if we look at where we were 20 years ago with bone grafts, you know, we were using autogenous bone grafts for pretty much any indication. We were using Calvaria bone grafts. We were using, fairly aggressive treatment protocols. And we came to understand that we can use xenografts, for example, for sinus augmentation by themselves. They work wonderfully. So I think research for tissue substitutes, it's getting there. I think we are seeing more and more research with collagen matrices.
But we're still not there.
But I think for this type of indications, I think for simple things where the implant perhaps is well positioned, where we have enough keratinized tissue, these matrices and these substitutes, they're not going to create keratinized tissue. They will create volume if you use a bilayer technique. Because
as we said, they act as scaffolds.
Yeah, they act as a scaffold.
It's the biological understanding.
So I think, you know, for simple, straightforward cases, I think they can work. But I think when it comes to the time to resolve this, they're very challenging indications. We have situations where we have no volume at all, where we have implants that are placed buccally, where we have barely any keratinized tissue. I think these, for me, are clearly indications
or maybe ponting
sites,
not necessarily around implants or places where you need it for prosthetic reasons. For example, the augmentation of soft tissue volume per se, without necessarily accompanying it with the implant.
Yeah, this could be an indication, but if we focus on the topic of dehiscence around implants and complications, to me, there's no space for this at the moment, and maybe at a later stage, maybe in 10 years, as we've seen research evolve.
And now I will tickle you. What about the magic recipe? LPRF. Okay, you have presented you knew I would get to you.
Of course I knew.
And you have presented, you don't like me calling it LPRF?
Well, I said let's be careful with the abbreviations. Let's do at least once tonight, tell our viewers who are not familiar with the technique what it stands for.
Gerhard, you can do it.
No,
come on, Gerhard, you're one of us.
I've been part of the EAO for way too long. I think it's leukocyte platelet-rich fibrins, right?
Perfect.
Exactly, there we go.
Excellent,
Thank you for
excellent.
challenging me in the primetime debate. All
Yes, you see, Gareth, you never know what surprise occurs. So,
But the question is serious.
Andy, I am very serious here. Now, we have listened to, the EAO has organized a phenomenal consensus conference where we have published a report on the use of LPRF. There is an enormous noise around the use of LPRF. And to be very honest, from the guts, from the heart, I think that there is a very high potential, but there may be a lot of maybe marketing, pushing, data derived from non-oral indications, but from more of a dermatologist indication, from the dermis, for example. Give us an insight, because when I was listening to you, I truly, honestly, you were very good, because I was like, great, I'm going to use it tomorrow morning. I mean, I'm not going to say I'm going to open a shelf or a drawer, because it comes from obviously our patients, which is, but when do we, what is it? What is the truth behind this, please?
Well, I get that question like every time.
I get it.
And that's probably because I'm from a Catholic university, and you think that I have some magic tricks, and that's not true. Nevertheless, what you say about dermatology and those, I've seen those things with my own eyes. Yeah, okay. And we're not going into detail in that, but this is amazing. Yeah. So, but this is not oral surgery. Let's stick to the oral surgery part. Is it magical? No, of course that's not magical, but it has the difficulty with all the papers that we have now is the abundance that has been published in the last 6 years. So that's one thing. So the quantity is immense now. Then you have the second part is that there is no consensus on how to use it. For example, ridge preservation techniques.
Correct.
Most of those papers just put one LPRF clot into the socket, but this does not work.
That's what I wanted to tell you, exactly, because this is why are we carrying on talking about that indication when, frankly, if this is really true, what you are advocating and the science behind it, which makes sense, we would need it for the extreme cases, for cases where we really need the added value.
But that is what I was trying to say. If you want to use it for a ridge preservation technique, then we have studies from our group which are good. But it's not like we have an extraction socket and I throw in an LPRF and it will immediately grow bone. No, that's not the case. If you, for example, extract a central incisor, you will need 6 fibrin clots. And to make this fit, this takes time, and it has to be done in a proper way. So it takes you 15 to 20 minutes to do it in a good way. As, for example, you also do with a soft tissue punch. You don't do a soft tissue punch, you do like that. No, you suture it nicely and so on and so on. So it's not like we throw it in and it magically creates bone. No, you have to do it in a proper surgical way. And then you will see in those studies that most of those studies have good results. And now the second difficulty is that LPRF has been used or is used in every part of implantology. Yeah, so that's also very difficult. Right? So we use it for ridge preservation, we use it for sinus augmentation, we use it for GBR, we use it for soft tissue, we use it for that.
So you're saying that we don't have specific indication with very well-structured studies that can really answer these questions.
We have those for ridge preservation, I think.
But the ridge preservation topic, let's put it aside for the time being. Because
we have it for sinus augmentations.
Correct.
Yeah.
But today we are talking about soft tissue. I can imagine if I look at your pitch and you're using it for soft tissue augmentation, when you listen to this medieval autogenous grafting, I think you heard, no?
I don't think this is medieval. I was a little bit
surprised
by Arthur that he says this is medieval. If you do a free gingival graft and you do it in a proper way, you know the study from Mino Burkhardt, if you do it in a proper way, then this is not really too bad for our patients. And
I agree.
LPRF has the capacity of being fixed to the donor site, and then we see results. Like patients after 3 to 4 days, you cannot even see where we have cut the tissue. So think about not only PRF as the replacement of the autogenous tissue, but also to help your patient to form a soft tissue healing point of view, and that is also something completely different. Also on the grafting side.
Which it reminds me of the concept of tissue engineering, the concept of applying the platelet-derived, for example, growth factors, which obviously have specific characteristics, like the androgenetic effect that you were mentioning of the LPRF. And here comes now my question that is really, yes, Arthur.
Yeah, I would like to, I was quoted there, so I'd like to defend myself.
Of course.
It is, I think it hurts. You know, the patients don't like, most of them come that need root coverage. They heard or read on Google, they said, I want the other option. But even from the anesthesia, it already hurts, okay, at the palate. And there is some, no matter how well trained the professional is, there's always some complications. And we are moving forward to eliminate this procedure. And I think we're very close to it. Why is that? The only problem that we haven't covered yet is the question of changing the phenotype. But there are many other studies going on where you can use it as a matrix, and with this material carried on to the recipient site, you'll be able to form, to change the phenotype. We're very close. The thickness, we have already a new material being sold, which is very, very thick. So it's not just 1 or 1 millimeter in thickness, it's 8. So this already takes care of that problem. The only problem that we have with the allografts is the ability to change the phenotype. But we are there. Root coverage, they're just as good. And for some areas around implants, they're just as good. So, but it's something that we are aiming for, to eliminate. I know that's still necessary.
Well, certainly,
and
Arthur,
I do it if I have to.
Let's hear a response from Ignacio.
Certainly, this is the aim of many clinicians.
I mean, I think I have to disagree with Arthur, because I think it's a good basis that we look for alternatives when we see that things don't work. But I wouldn't be so radical. I don't think it's an excuse that just because it hurts the patient, we have to just move away from them. I think there are techniques, there's training that we can do, and we can do this with fairly minimal amount of pain. So I'm totally for alternatives. I think we need to identify where they work. But I think that soft tissue, autogenous soft tissue grafting is here to stay. We can just not look away from it and say, it's a thing of the past, just because there are things that are emerging. I think also the science is not quite there. Maybe for certain, class 1, class 2 root coverage, yes.
Of course.
But certainly not around implants.
And again, we are always talking about the indication, if you think about it. So we really, as you were mentioning, it's like the LPRF topic, we really need to specify and give ourselves the indications, because what we treat, we cannot treat every case with one solution, let's put it that way.
Exactly, but the aim of this debate is to figure out where are the boundaries of what we do. Eh? So I wonder, when you say that, Ignacio, what is your strongest argument to stay with autogenous as long as you can?
So if I just can once again focus the discussion, we're talking about soft tissue complications around implants. And when we're dealing with these cases, there are very often other problems around this. We've talked about malposition of implants. We've talked about thin soft tissue. We talked about buccal hard tissue deficiencies. These are not situations, I think, where you want to bet on an alternative. I'm totally up for in other indications, but in this type of clinical situations and clinical scenarios, I think autogenous, if we want good results, is the treatment option of choice, at least for me.
Yeah, so you basically say there is at the moment no room for experimentation if we are in a situation where things go wrong.
In this type of clinical cases, we have frustrated patients. They're tired.
For sure.
They don't want to go for the next new fancy thing. They want the thing that works, and they don't want to see you again.
And I believe that we have, our approach has to be ethical enough to be able to offer our patients treatments when we have a solid evidence and a solid background behind this. This, I think, has to be, set in stone. Now, I have a topic that burns inside. We often hear nowadays that when we use membranes for augmentations, we're talking about soft tissue dehiscences, whether it's resorbable membranes or whether it's non-resorbable membranes, the soft tissue, yes, of course, plays an important role. Everybody speaks, oh yeah, the flap should be tension-free. We have improved thanks to great papers how to manage these soft tissues, and with a combination of learning how to perform these surgeries, the combination of having new generation, for example, PTFE membranes, and so forth, the percentage of complications, i.e. soft tissue dehiscences, is decreasing. However, we still hear the famous sentence, if something dehisces, so if the soft tissue opens up, it does not matter if it's a resorbable membrane. Do you remember we were discussing this when we were, earlier on we were talking? And even when you use a PTFE membrane, there are some specific indications, primarily the socket preservation or the alveolar ridge preservation, where you leave a PTFE membrane exposed and you eliminate it after 8 to 10 weeks to allow for secondary healing. Now, can we please discuss about this? Because this is something that I have at heart. I believe that every GBR procedure has to have a primary closure, full stop. So tell me if you agree, disagree, and in this in this scenario, I want also to understand whether the LPRF in these scenarios where it's dangerous, let's put it that way, to have a soft tissue dehiscence could improve our result. This is something that I want to get through tonight.
If I can just bring a small piece of evidence, I think we published a paper in the Journal of Dental Research in 2016. The first author is my friend Ignacio Sanz Martin. And what we did is, with a systematic review and a meta-analysis, we evaluated what was the impact of dehiscence and exposure. And what we saw was that, obviously, the impact was for resorbable and for non-resorbable membranes, there was clearly a negative impact in terms of exposure. But it is true that obviously if you get a non-resorbable membrane exposed, the negative impact is even more noticeable. But obviously when you also have an exposure with collagen, you're also going to have some degree of...
I know, but still nowadays, people claim that you can, in a way, leave them exposed and it is okay and everything will go back to normal. So can we please, we have a very sophisticated audience following us, and I think we have very high numbers of people following us. And I'd like really, honestly, to give a very, very, strict take-home message that when GBR is performed, regardless of the use of the membranes, we're not getting into that indication, we have to achieve a primary closure. You have shown the case where you allowed for a secondary intention, and you yourself said that the soft tissue was impaired and the volume you had to regraft upon re-entry, but that's understandable. So why then do we have this message coming across in the community?
I think it's the wrong message that we are giving, because we should aim for a primary intention healing. And I have a lecture on this, and it calls the devil in the details.
Correct.
Yeah, because there are so many little details when you do augmentation procedures. For example, I just gave you one example, the suturing.
Yes.
Suturing, there are so many different techniques you can use. There is also, if you look to general surgery, there are some papers that are discussing the bite size, the distance between the sutures. This is something that I never hear on congresses or in lectures. So I looked into this, and this is also important, and these are very little details. When I was a postgraduate student, I did an augmentation, and I had to suture. I was like, oh, I'm done. Yeah, and I was done. Now you're starting to recognize that all those little details really matter in order to give actually a chance for your surgery to survive. And this is also why we are incorporating something that is trying, if there is like the least amount of dehiscence. For example, if you take your flap with the tweezers and you look under the microscope, there you sometimes see pinches inside. These are little dehiscences that you create as being your own surgeon. And
so can we ask you and your group to look into the potential use of LPRF under, for example, the flaps during a significant augmentation?
We started a study
to see. Correct. So we will, Gerhard, make a note. We'll have to come back in a few years and discuss this to be able to have some science behind this. What is your opinion on this? Why? I mean, you showed us a case by secondary intention, so you allowed this. Is this your normal regime?
Absolutely no. I want to cover by primary closure and have a healing without any complication. And I'm convinced that, first of all, we should think about our techniques, what we are using for techniques, I'm convinced what materials we are using already. But going back, more important is to understand what incision lines we have to make to get a perfect blood supply. And of course, it's so necessary to have a tension-free closure. If you see in courses people what they think is tension-free closure, it's totally wrong what they think about. So it's a technical thing. I'm convinced it's the main important thing. But what we never focus really is the thickness of our flaps. And especially in the lower posterior, where we have so much movement from the muscles and where we can get very easily exposure, why we have not a critical threshold for primary closure on soft tissues. We know it in plastic surgery, in root coverage, but not in our 3D augmentation procedures.
Well,
we need new studies, what we need, you know, on tissue to have a predictable outcome.
Gerhard, there are the studies by Is van Orben who have shown us, in fact, that he studied the tension and the difference of various flap in the posterior mandible. And in fact, in a way, we have improved the release exactly for this reason, the release of the flaps. We have learned a lot from this. So shall we start wrapping up?
You can start to wrap up, but not before. I mean, we are live. It took a while, but I have an audience question. So let's do a quick last round. And this is quietly related to what we're talking about, Isabella. The question is about, can the flap still be sutured after dehiscence?
Oh.
No.
If you ask me, the answer is no.
Simply
go.
No?
No.
Arthur, no? Everybody is clear on that one.
Yes,
So
but
nothing to be saved there.
Actually, it's extremely dangerous to suture back. And this happens often because the surgeon, in a way, wants to patch up.
Exactly, you try to save.
You try to save, and it's a very important message. Please don't, because the infection is there, and it will blow up even more. I hope you all agree. So
that's a good question from the audience and a very clear audience from, or a very clear answer from all our debaters. Sure.
So, do we have another question from the
audience?
Well,
we have a few, but there are basically touched on already. Long-term results. We all say there's more study needed to be done, both in the xenograft as in the LPRF field.
So as I see what we have touched today, we have tried to brainstorm on soft tissue dehiscences or soft tissue impairments or problems, and what we have heard is strong statements that the connective tissue graft may be obsolete, but on the other hand, in fact, it is not, and it goes down to the indication. So Arthur, let's aim for finding something that will substitute our autogenous graft harvested from our patients. We all agree that if we had a magic wand, we would have this, but at the moment, we're not talking about magic, we're talking about science, and hence, we still need the autogenous graft, and we have improved our ways of harvesting in order to apply it to specific indications. On the other hand, in 2020...
Yes, Arthur, come in.
I said it will be obsolete soon, but for now, there are several indications.
There we go. We are agreeing. Okay, so you see, this is why I like to summarize and to wrap up, because at the end I want, to have a clear message. And as I was saying, we're in 2020, which means that, who knows, in 2025 we may sit around the table like tonight and we may say we have found something that may at least play the role of the autogenous graft, which means then obviously a superiority because you avoid the morbidity. Exactly. And that's one take-home message. And in terms of, for example, the research that you have shown, Andy, this is very encouraging. We still need data to be utterly and deeply convinced. We want this to really help us, and I understand the biology behind it. And I think there's a lot of understanding because of this, which can bring us. And I would see this in the more extensive and severe cases. I think it's we put aside the more standardized cases like the sinus lift or the alveolar ridge preservations.
Yes.
So.
Now, if I may, what I would like to do to really wrap up the debate tonight is to challenge you. You have a few minutes left. If there's one thing, after listening for 1 hour to this whole debate about how to deal with soft tissue when things go wrong, what is the one thing that you really want to underline and want this audience to write down and tweet out and remember from this debate? Gerhard, may I invite you first?
Yes. In cases of any exposure, clean it and avoid infection by using topic antibiotics with ointments who glue to this tissue. This is the key for me.
The key for you,
yeah.
Great. Arthur, if I go to you, what is your key take-home message that you want to underline?
Well, not on my subject, but although you don't like it, the LPRF, I think we have some consensus regarding soft tissue, but no consensus regarding bone formation. And I'm kind of afraid that everybody goes home thinking that LPRF is a problem solver for bone formation.
No.
I think Andy was clear on that. But good, you want to. That's what you really want our audience to understand. It's good for soft tissue, but not for everything. Thank you, Arthur. Ignacio, what do you want to underline?
So my topic was dehiscence coverage around implants. I would say first, do you treat the case, do you don't treat the case? You know, if the implant is way outside the alveolar envelope, use a probe to look from the occlusal part. If you see the shoulder of the implant, the head of the implant outside, you know, fairly outside, above 2 millimeters, you need to start thinking about taking the implant out. If you're going to treat the implant out, you're going to have to somehow compensate for the position of the implant. Either you're going to have to use some angled abutments to leave some space for the soft tissue, and when you use the graft, to use something thick, coarse, that has mainly lamina propria.
Go back to the root of the problem.
And for me, clearly autogenous.
Yeah. Andy, final words?
I'm not going to finish with LPRF, something completely different.
Maybe something with xenograft?
No. Something completely different. I think we should also prepare our patients from an oral hygiene point of view, and so on and so on. This is something that I see on a regular basis, that we see you do an incision where there is dental plaque everywhere. This is asking for problems. I'm a periodontologist, so I want to end with the oral hygiene.
I think this is a fantastic way to finish off, because at the end of the day, it's the planning, the preparation, and of course, the whole patient in its entire picture, and not only where we put that incision.
Exactly. Well, thank you, Isabella, Arthur, Gerhard, and Andy, and Ignacio for this very insightful exchange, and very brave of you to come on to the primetime debate here in the EAO Digital Days. And thank you all for your active participation so far. So once again, I invite you to briefly reflect on what you've just heard and share your insights with hashtag EAO Digital Days on Twitter, Instagram, LinkedIn, or perhaps straight into our EAO Direct Facebook group. Or you can just follow the European Association of Osseointegration, also known as EAO, on your favorite social media channel like Instagram, Twitter, or Facebook. And you will get the behind-the-scenes updates and the latest news. And you can just share that with your colleagues and friends with a simple click.